All right, good afternoon, everybody. Today we're giving the first of what's going to become a regular briefing with regard to our COVID-19 vaccination program, and of course it's an opportunity for us to share other messages regarding our overall COVID-19 response. Shortly the Director General will provide an update on case numbers as per usual and any other COVID-related information, and then we'll take some questions. Yesterday, Cabinet confirmed formal government approval to use the Pfizer COVID-19 vaccine. This was something that we foreshadowed last week we would be considering at Cabinet. This is another critical step in the process of ensuring that our vaccine is safe and effective for New Zealanders, and it follows the provisional approval that was granted by MedSafe last week. Cabinet considered and has endorsed the COVID Vaccine Technical Advisory Group's decision to use recommendations on the Pfizer vaccine. Those recommendations are that the Pfizer COVID-19 vaccine is suitable for use in New Zealand for those 16 years of age and over, and that adequate information should be provided, particularly around expected common side effects, for example, fever, muscle pain and fatigue. A 30-minute observation period is required after the vaccine has been administered. Patients receiving specific therapies should not receive the vaccine, and those have been listed. Pregnant women are advised to discuss the risks and benefits of having the vaccine, the Pfizer vaccine, before they did so, and that the vaccine is suitable for lactating women. It's also worth stating that the group's recommendation that the Pfizer vaccine only be used for people aged 16 years and over is based on the lack of clinical trials so far of those under the age of 16, and it is therefore subject to change as additional evidence is made available. As the Prime Minister said last week, we will be aiming to start vaccinating our border workers within days of our first shipment of vaccine arriving in New Zealand. We will also be looking to vaccinate as a matter of priority the people who they live with, their closest contacts. While that continues to take place, or while that starts to take place, we will continue to receive advice from officials on the other vaccines in our portfolio. MedSafe is already in regular conversations with AstraZeneca and Janssen, and they've begun engagement with Novavax. Similar rigorous approval processes are being followed with all three of those other vaccine candidates. We're making very good progress in the logistics for the immunisation campaign and the rollout of the vaccine when they arrive in the country. Final checks on 7 of our ultra-low temperature freezers will be completed in Auckland by the end of this week. The remaining 2 freezers have been moved to Christchurch so that they can support the rollout in the South Island, and they should be fully installed and all of the checks completed around 2 weeks after that. We've also purchased special containers that will allow us to transport the vaccines around New Zealand at ultra-low or cold chain temperatures. And we're planning for an extra 2,000 to 3,000 full-time or full-time equivalent vaccinators to be trained and available throughout New Zealand. So far, more than 1,800 people have registered their interest in being involved. In addition, more than 2,000 people have been trained as provisional vaccinators, and they're ready to complete the COVID-19 training once that is available. Work is also underway to develop the comprehensive new National Immunisation Solution, or NIS. That's already been built and it is available to use now, but it's we're continuing to improve that in this period while we wait for the vaccines to arrive. And vaccinators will be trained on using that shortly. Once it's implemented, any health worker, any authorised health worker around the country will be able to record vaccinations in that system anywhere, anytime. It'll be able to prove vaccination for COVID-19 and confirm someone's vaccination history. Over time, our goal is to enable members of the public to be able to digitally access their own vaccination records, and the immunisation solution has been built with that in mind. Next week, our vaccine information campaign will start, and I've got a few important messages about that. It is going to ramp up through the year as we reach each phase in our vaccination campaign. So it will reach its peak when we reach the point where we're starting to make vaccines widely available to the general public. As we enter this next phase of our COVID-19 response, it's more important than ever that New Zealanders can access reliable and trusted information about the safety and efficacy of our vaccines. That means that they will be in the best position to make informed decisions for themselves and for their whānau. Equally important, we've got to remember that some people may try to take advantage of people's trust and confidence with scams and misinformation, and that's something that we're working actively to combat. The COVID-19 vaccine rollout does create an opportunity for online scammers to take advantage and to disrupt the process. And we've seen examples of that internationally, and we saw that kind of behaviour during our own lockdown here in New Zealand, where scammers were opportunistic and they looked to trick people into divulging personal financial information. The government cybersecurity agency, CERT-NZ, is working closely with other government departments to try and stop these scams in their tracks. Key things people should know about this. The vaccine will be free, and at no point will you ever be asked to pay to secure your place in the queue for a vaccine. Any communication about the vaccine will come from the Ministry of Health or other trusted sources. If you receive emails out of the blue or other electronic messages out of the blue asking for financial and personal details associated with our COVID-19 response, it is likely to be a scam. The best way that you can help to stop these scams is by reporting them to CERT-NZ via their website. I also want to acknowledge that we have had messages from Google and from Facebook in recent days. Facebook's told the government that it will be expanding its efforts to remove false claims on Facebook and Instagram about COVID-19, COVID-19 vaccines and other vaccines in general. Facebook has updated its policies in order to keep people informed and to limit the misinformation that can be spread around COVID-19 and around vaccines. We also know that Google searches, and let's face it, we all do Google searches all of the time, can be a primary source of information for people. So Google will be running a worldwide campaign to promote authoritative information about COVID-19 vaccines, and information about the New Zealand vaccine campaign will be part of that. We are developing a campaign to ensure that all New Zealanders get the information and assurance that they and their whānau need in preparation for the rollout of our vaccine. We've seen from other programs that the ability to access sound, reliable information is the key to ensuring that we get a strong uptake of the vaccine. So making sure this information is readily available from sources that people can trust is a priority for us as we get our campaign underway. I'll now hand over to Dr. Bloomfiled to give you the day's daily update, and then we'll take your questions.
Thank you, Minister. Kia ora koutou katoa. I'm pleased to say our numbers today are very straightforward. There are just 3 new cases of COVID-19, all in managed isolation to report since our media update yesterday. 10 previously reported cases have now recovered, and so the total number of active cases at the moment is now 59, and our total number of confirmed cases is 1,968. On Tuesday, our labs processed 2,845 tests, and the rolling 7-day average up to yesterday was 3,750 tests. From this week, our updates are now going to include a running total of historical cases to date since 1 January 2021. We are seeing an increasing number of people who have been infected abroad and recovered, and some people indeed in New Zealand who have been previously infected and recovered. Our testing in these individuals may, sometimes it doesn't, but it may detect some residual viral material because the PCR test is very sensitive. It's important to reiterate that these historical cases are not considered infectious, and so we will not be calling them or reporting them as acute cases. We will report them each time they come up, though, as historical cases. So since the 1st of January this year, there have been 25 such cases that we have determined to be historical, and that's out of a total of 158 cases. All those historical cases are ones that have been previously reported. In terms of the NZ COVID tracer, there were 603,000 poster scans since midday yesterday. Just another comment on vaccines. Further to the Minister's announcement, I just wanted to also reinforce the role New Zealand continues to play internationally, and specifically with the Pacific countries that are participating in the government's Pacific Health Corridors program, which the Ministry of Health and Ministry of Foreign Affairs and Trade lead. The countries that are involved, which are the Cook Islands, Niue, Tokelau, Samoa, Tonga and Tuvalu, will be offered access to vaccine through the vaccine portfolio that we have negotiated with the 4 providers. We're also working closely with our Australian counterparts and other partners, including the WHO and Gavi, to ensure countries in the wider Pacific have the support they need to run successful immunisation programs. We're currently in discussions with each of those 6 countries that are part of the Health Corridors program to see what their specific needs are, both in terms of vaccine and also wider support for their vaccination programs. And this is just an example of our wider contribution to the global response and international effort on the pandemic. And finally, on a different topic, I'm aware there's strong interest in the rapid review that Associate Minister of Health, Minister Verrill, announced this morning into the lead contamination of the water supply down in Waikuiti and Karatani. And that was announced this morning. That community testing of residents in Waikuiti, Karatani and Hawkesbury started yesterday, and 282 people were tested in around 3 hours yesterday. I would like to encourage people in those communities to get tested this week at one of the testing centres that are available at various times over the next few days. And just to reiterate that tests are free. I would like to also thank the team at Southern DHB and Well South, the public health unit there, for quickly standing up the testing centres and providing the community with the opportunity to seek information and have questions responded to. The results of all the blood tests will be looked at and they will be key in determining whether and what level of any lead contamination there is and the potential risk, if any, to people's health. Obviously, individuals will receive their individual results back as well. We will communicate the overall results to the wider community at a public meeting and also, of course, with the media. And just regarding that rapid review of the health response into the contamination, which I've initiated, this will be done by independent experts, and I will update you and announce who those people are and release the terms of reference for that review later this week once I've just confirmed the reviewers. One of the things I'm particularly interested in is as we transition to the new Three Waters regulator, Taumata Arawai, from July, what, if any, lessons there are from this particular incident that they need to be aware of and take on board, particularly as we go through that transition period, and how that interaction continues with our health agencies so that we continue to provide support for that new regulator. And I do want to finally reassure the communities involved we're taking their health concerns very seriously, and that's one of the reasons I've initiated the review. Thank you, Minister.
Thank you. Happy to open up for questions.
Minister,
Jessica.
when will the vaccines arrive?
Look, we don't have a firm date at this point. We've told our district health boards to be ready so that whenever they do arrive, we're in a position to get underway very quickly.
And when you talked about the freezers, you said it would take, once they arrive, it would take 2 weeks to set those freezers up in Christchurch. Will there be any delay in getting vaccines because the freezers will take 2 weeks to get going?
No. Our key focus here is on getting our border workers vaccinated. We are able to transport smaller quantities of vaccine around the country. Obviously, the freezers in Christchurch will be critical once we reach the point where we're having larger volumes of vaccines that we're needing to store.
There's also a report out of Europe, and perhaps this is a question better directed to Dr. Ashley Bloomfiled, from the UK government saying that the Pfizer vaccine and the Oxford AstraZeneca vaccine, that they've reported on side effects and are reporting that 1 in 333 people have had quote unquote adverse reactions to that. Is that standard practice with a vaccine, or are those numbers seem high?
Mm-hmm. Yes, I just read an update from our technical advisory group this morning on this particular issue. There is nothing out of the ordinary with the rates of side effects, both mild and moderate, right through to more severe. Some people do get a severe allergic reaction. There is nothing out of the ordinary compared with other vaccinations that we already have. So one of the things is that these vaccines are, in the clinical trials, have been shown to be quite what we call reactogenic, and particularly sort of some tenderness, soreness at the site. A reasonable proportion of people will have mild symptoms such as a bit of fatigue, maybe a little bit of muscle aches, but in virtually all those trials, it's just mild to moderate. We haven't seen anyone have severe effects. And in terms of the one in, was it 330, it's probably just people who may be feeling more, more at the symptoms are more noticeable and they may need time off work.
So we shouldn't be alarmed by that stage?
No, the rates are very much in line with other vaccines.
We'll come over here.
While you're, obviously it's very important the vaccine arrives, everyone wants it to arrive. Can I actually ask, what do you actually do to try and hasten it? Do you negotiate? Do you text your contact? Do you email every hour? Like what can you do?
Look, we're in regular contact, particularly with Pfizer, because that's the vaccine that we're now ready to go with as soon as it arrives in the country. When I say as soon as it arrives in the country, I should note there is a period of the first, couple of days where they have to do their safety checks to make sure that the cold chain has been preserved during the transportation, that it then has to be unpacked and repacked for distribution through the country, and that takes a period of time. So I'm not saying that the minute the plane lands we're going to start, dishing out vaccines. There'll be a period of a couple of days where we have to get everything underway, but we want to be in a position where as soon as that process is completed, and literally that process is mapped out hour by hour from when the plane lands to when the first person gets their vaccine, we want to be in a position to be able to get underway as quickly as we can. Now, the delivery schedules that have been discussed with the vaccine companies, we're about 70% confident in, but having said that, at this point, we haven't shared those because everyone can see what's happening around the world, and those things are subject to change.
How did you get to 70%?
Based on the vaccine companies, well, in this case Pfizer, based on what they're telling us around their degree of confidence that they can deliver to that schedule.
Can we assume that you are not expecting any vaccine to arrive in February?
No, you can't assume that. But what I'm not going to do, and you've seen other countries around the world, I'm not going to say this is what our draft delivery schedule is, because then when it changes, we then have to go back and tell everybody that it's changed again. So we will let you know as soon as we will be notified as soon as the first shipment of vaccines put on a plane to come to New Zealand, and we will then let you know that it's on its way. Up until that point, I'm not going to put any particular time frame on it, but it could be February, it could be March.
Dr. Bloomfiled?
Can you explain specifically why we're going through COVAX to secure more of the Pfizer vaccine?
We were asked to express, or to put forward expressions of interest as to whether we wanted to secure additional Pfizer vaccines through COVAX, and particularly if we could get earlier access to the Pfizer vaccine through COVAX, whether we would want to do that, and that's the process that we have engaged with. We are very committed to that facility, to making sure that there is equitable distribution, and to make sure that those most at risk, those higher priority groups, are able to get access to the vaccines as quickly as they can.
If we are seeking it, are we then taking it sort of out of the hands of the developing countries who need it perhaps more? No,
that is the point of the COVAX facility. It's to make sure vaccines are distributed equitably.
Is it appropriate for an MP to be travelling overseas at the moment?
Look, I don't know that person's individual personal circumstances. We're a very international country. What I can say is that in terms of that exemptions process, that emergency allocation process, and all of those other variables that we've seen over the last few months, New Zealanders do sometimes have compelling reasons to travel internationally for family reasons and so on. And so I'm not going to pass judgment on those, but the criteria for getting an emergency allocation to get back into the country is a very high one.
Are you confident that all that was handled appropriately in terms of Ricardo Mendes March's return to the country?
Yes, I was notified through MB of the fact that he was seeking to return to New Zealand, and I indicated that I was not going to get involved in that decision-making process in any way, that was ultimately a decision for the Chief Executive of the Ministry of Business, Innovation and Employment, who oversees that process, and that she should make the decision based on the criteria that she was confident with, and that I wasn't going to involve myself in that process.
Why was it declined?
What was that?
Why was the emergency allocation application declined?
Because he didn't meet the criteria.
Has the Labor Party received any sort of instruction from leader or chief of staff or whoever, specifically not to travel?
No, the Prime Minister, and whips, depending on whether you're a minister or an MP, have to approve all international travel in the Labor Party. And my understanding is that no international leave applications have been submitted since the beginning of this, the COVID-19 response.
No strict instruction around it at all?
Well, there doesn't necessarily need to be, because their applications just wouldn't be approved, unless there was an exceptional reason for them to need to travel.
Dr. Bloomfiled, emails show when the first group of Russian fishermen arrived here, many with COVID-19, officials had not seen their test results, didn't know when they were tested, and didn't know anything about their isolation in Moscow. Has the information flow now improved?
I would say it has, and we were able to get that information very quickly once they did arrive, and the company that arranged to bring them over was very helpful in getting the information about both what they had done before they travelled and also the test results. And you would have seen with the second cohort of fishermen that came through in early January that we had a much smoother process through managed isolation without any of the issues that we had had with the first cohort.
Can I just highlight here, this is an example which we've talked about regularly of the system learning. So there were some issues with our first cohort of Russian mariners, and as a result we took the time to really debrief about that, to figure out how the system could be improved. And all of the recommendations for that were implemented in time for the second cohort's arrival. The second cohort was very, very smooth. We didn't get any issues, and I want to thank everybody that was involved in that process.
But at the time with that first cohort, you did say planning for bringing the men in was rigorous. Do you think that is still the case?
Look, I think there were lessons that were learned, and they were captured in the review of that first cohort, including the things around having two people in a room, and that was certainly one of the reasons that we saw some transmission between people during that time. And so all of that was resolved by the time the second group arrived.
So that first cohort, that planning wasn't rigorous at all then?
Look, it was very rigorous, but there were some other factors in there. The plane was delayed in leaving Moscow, which meant that they were in Moscow for about 48 hours instead of a short period of time, which meant their pre-departure testing perhaps wasn't as useful as it might have been. There were a whole lot of things that contributed to that first set of events, and I think that everybody has learned how we can do things better to make sure that doesn't happen again.
And just with that second cohort, when that second group also landed with COVID-19, are you actually satisfied that the Health Ministry is actually getting clear and accurate information from Russia?
Yes, I am, but pre-departure testing, and we've said this all along, it's not a magical solution. Even with pre-departure testing, even with good rigorous pre-departure testing, we will still have people coming into our managed isolation facilities who bring COVID-19 with them, because they can pick it up in flight, they can have picked it up between when they get their pre-departure test and when they depart, they can pick it up in transit, they could have picked it up just slightly before they got their pre-departure test and wouldn't necessarily show a positive test result. So it is by no means an absolute guarantee. It is an extra layer of protection, which is why we've gone with it in light of recent developments internationally. Yeah.
On the 70% sureness, is that 70% sureness they'll meet those delivery schedules or your goal of first quarter arrival?
That's the delivery. That's the particular delivery schedules.
What percentage sure are you that it will arrive within the first
Oh,
quarter?
I'm very optimistic that we will have our first shipments in the first quarter. In fact, I'm quite confident we'll get our first shipment in the first quarter. But whether they meet the particular sort of day by day, I've indicated this previously. They've indicated to us that it won't all arrive in one shipment. Or one plane load. It will arrive over a series of weeks in smaller batches, and I'm absolutely confident that we will that the overall first quarter target is still achievable. But that particular timetable of week by week is still, there could still be some movement there.
Can I want to ask about MIQ facilities,
Yes.
because there's been reports of hotels wanting to move away or thinking about moving away or whatever else. Will that number of beds provided by the government for MIQ, are you aiming to maintain that throughout, no matter what number of hotels move in or out or choose not to or whatever?
Look, I'm aware that for the people who own those hotels, a public bargaining process is something that they'd be quite keen to engage with. We won't do that. Obviously, we're in contract renewal negotiations with the hotels. We're seeking to get a longer-term contract with them to provide some more certainty. We do have an ability to dial that back, though, if we needed to wind back our managed isolation program. Because we didn't need those beds anymore, we're building that into the longer term contracts that we're negotiating. But obviously that's a commercial negotiation process, and I need to let the people who are doing that negotiation get in and do that.
Are you seriously looking at reducing the number of overall MIQ beds though? Because obviously the demand is so strong you can't get into one for the next 3 months.
No, we wouldn't be looking to, unless there's a good reason to, unless we had to. But we'd certainly like to keep the number of beds that we've got, or the number of rooms that we've got, I should say, around about the same.
With the barrel on this, aren't you?
Look, there's other hotels out there that we could speak to as well. The ones that we've got are the ones that we think are the best ones to use.
You said in the past that you couldn't expand it further for there weren't suitable hotels.
Well, we may have to look at other alternatives, but at this point, we've got a good relationship with the owners of the hotels. I think that we'll be able to resolve the contract negotiations.
I've got 2 questions
Yes.
about the Pullman. First of all, the Hamilton case, Dr. Bloomfiled, there's going to be more genomic testing. Has that been done, and can you rule out that that person actually caught it from, the Northland woman who was on the same floor? And second, and then I'll ask.
So we're very confident there was an historical case. The pattern right from the start suggested it could be historical. We took the approach of managing it as if it could be an acute case, although we knew that the risk to the wider community was low just because of the pattern of the person's movements once they left managed isolation. The fact of not being able to get a whole genome sequence reflects it being an historical case, so there's very little viral material there. We're still waiting to see if they could, with a rerun, get the whole genome sequencing. I would be surprised if they can. We're confident, and we have categorised it as an historical case.
And when are you going to get the ESR report on the Pullman?
Sorry, that did come through. They weren't able to pick up any traces of COVID-19 in the environmental testing that ESR did, which lends itself, so I'm advised, to the notion that it could have been droplets in the air that would have been temporary. So they would have only been there for a short period of time, and people could have literally passed through the same airspace, and that there could have been transmission that way, rather than there being some, environmental contamination, if you like.
You'd spoken previously about doing a bunch of upgrades around air conditioning. Has that all been done now?
Yeah, so the reviews have been taking place between health and the MIQ team, looking at the airflows in each of the facilities that we operate, because they're all different. They've got different air conditioning systems, different window arrangements, different corridor configurations, and so on. In the case of the Pullman, a change that's already been implemented is to create positive air pressure within the corridor spaces by keeping the air conditioning running 24/7. I indicated previously that hotels typically would purge fresh air into their common spaces several times a day, but they wouldn't have that operating 24/7. By operating at 24/7, there's positive air pressure, which means when someone opens the room, the door to their room, if there are droplets in the air, then they'll be pushed into the room rather than sucked out into the corridor. That's one of the reasons also why we ask them to close the window before they open their door, again, to make sure that there's positive air pressure there with the Pullman. Other hotels will be different depending on what their air conditioning and airflow systems are. So that work is happening. Upgrades to air conditioning systems are happening as well. One of the things that we're looking at in the Pullman is particularly around lifts. Lifts are difficult because the air tends to stick around in a lift, as to whether or not there should be additional air filters put into the lifts. Now that's a process that may take a little bit longer.
Question from a colleague. Why did you oppose setting up a regional isolation facility in Hastings?
Look, I certainly didn't. Actually, I think you're talking about there was a request for a bespoke managed isolation facility there. The issue there is around, partly around resourcing and staffing. So it's around making sure that we can adequately support any additional facilities with security, defence, health workers and so on, and that was ultimately the constraint there.
Dr. Bloomfield, on the issue of water that you talked about at the beginning, we've known that there have been issues with these water systems for a long time now. It's been publicly talked about for a long time. Is it acceptable that this was able to happen down south?
Well, two comments there. First is that the testing of the water supply down in these communities for lead and other sort of metals in there only started in July. And so there's no historical testing, and that's one of the reasons why we're wanting to do the blood testing of the community there. So I think, to put that in perspective, once the health teams were made aware of what the issues were, then they moved quite quickly. We will see through the review whether or not there could have been other potential points of intervention. I think the wider issue here, though, is exactly what's behind the government's reforms around the three waters, which came out, of course, of the inquiry into the Havelock North incident with Campylobacter. So it's acknowledged that there are gaps in our overall regulation of water around the country, both drinking water and wastewater, and that is what the establishment of the new regulator is designed to address.
Are you satisfied that these gaps are being plugged with the urgency they need? This is about people turning on a tap and having a glass of water.
Sure. So what I would say is, at the moment, the Ministry of Health remains the overseeing body for the regulation of water supplies, and we have been put in place a number of actions, including training and accrediting quite a significant number of additional drinking water assessors around the country to make sure that those assessments were being done. There have been a range of other actions that we have put in place while the new regulator has been established, and I can come back to you on with a sort of a description of the range of actions we put in place while we remain the regulator.
Minister,
Last question.
are you considering, or has there been any discussions with camper van companies again in order to create more space for managed isolation?
Look, camper vans aren't. We have looked at camper vans in the past, whether we could create sort of a mobile MIQ. Not a great option in the winter for people. Not a particularly comfortable experience for them. I've always said we never rule anything in or out, and so I wouldn't absolutely rule out using that. It may well be a good emergency response, for example, if we had an event that meant we had to evacuate one of our facilities. That might be a short-term solution that we could put in place. But it's unlikely to be part of our overall configuration.
What's the most preferred method of expanding the system, given that some of these hotels might move away?
The issue is not just hotels. So there's the physical space, but there's also the workforce to support them. And as you'll see from recent media coverage even, there's not an unlimited number of people willing to work in these facilities. And so we have to weigh all of those things up as well when we're considering whether we could open additional spaces.
Expand or maintain the capacity then, say the Sudima was to pull out.
Look, I'm not going to get into a speculative public debate about that whilst we're in discussions with the Sudima about their contract renewal. I don't think that would be a particularly good negotiating tactic.
It's increasingly not more than a hypothetical possibility though, right? You'd be planning for that.
Yeah, look, like I said, I'm not going to get into a negotiation around all of the ins and outs of a contract renewal and what we might do if we didn't get what we wanted.
I'm asking what the alternatives are.
Well, then I'm sure the Sudima would very much like to know that information.
You've actually talked previously about this, Dr. Bloomfield, in terms of Queenstown and it not being, because obviously they would love to have some business and not having like a proper hospital there. Is that, I guess, given the amount of times, which I imagine is not that many, that you've actually required full hospital care for people using MIQ, is there any sort of looking at perhaps relaxing that sort of fundamental need when it comes to places and where you might put facilities?
No, not at the moment. At the moment, we've got a really good arrangement and rhythm with our MIQ facilities and the centres we've got them, so we're not looking to extend the number of geographical locations.
But that will remain fundamental to where you can go, though, is having like a full hospital in that sense?
Yes, access to healthcare is really important, is one of the important dimensions, and that health workforce you require to actually staff and be either in or on call in the facilities 24/7.
All right, thank you very much, everybody. Cheers.